Hello, this is Dr. Hoadley, and we are going to learn about myocardial infarctions, acute coronary syndrome, and congestive heart failure today. Your heart is comprised of a four-chambered hollow muscular organ, normally the size of your fist. It lies in the thorax and the mediastinal space and separates the left and right pleural cavities. Your heart is composed of three layers: a thin inner lining called the endocardium, a layer of muscle, the myocardium, and the outer layer, the epicardium. The heart's covered by a fibrous serous sac called the pericardium, and this sac consists of two layers: the inside visceral layer of the pericardium and the epicardium, and the outer parietal layer. A small amount of pericardial fluid, approximately 10 to 30 mL, lubricates the space between the pericardial layers, or the pericardial space. This prevents friction between the surfaces as the heart contracts. If it's an acute situation and you get up to 100 mils in your pericardial sac, that could actually cause a cardiac tamponade, which we'll talk about later. If you have a chronic condition, you could actually have liters of fluid in that pericardial sac because over time it expands and allows for growth. The heart is divided vertically by the septum. The interatrial septum creates a left and right atrium, and the intraventricular septum creates a right and left ventricle. The thickness of the wall of each chamber is different. The atrial myocardium is thinner than that of the ventricles, and the left ventricular wall is 2 to 3 times thicker than the right ventricular wall. This is a diagram of the heart flow as it goes through the different chambers. And I'm going to put on my pointer so that we can talk a little bit better. Okay. The right atrium receives venous blood from the inferior and superior vena cava and the coronary sinus. The blood then passes through the tricuspid valve into the right ventricle, and with each contraction, the right ventricle pumps blood through the pulmonic valve into the pulmonary artery and to the lungs. This blood flows from the lungs to the left atrium by the way of the pulmonary veins. It then passes through the mitral valve and into the left ventricle. As the heart contracts, the blood is ejected through the aortic valve into the aorta and then thus enters the systemic circulation. If you look in your textbook, there's a schematic that represents the blood flow through the heart, and the arrows will show the direction of the blood flow, just as we had talked about it. And if you recognize from this drawing, the red vessels are oxygenated blood and the blue are deoxygenated blood. Also think about this concept that we know that the definition of an artery is a vessel that carries blood away from the heart, and a vein carries it to the heart. But if you think about when you have deoxygenated blood, it goes through the pulmonary arteries, so that is the only artery that carries deoxygenated blood to the lungs, where it picks up oxygen and brings that oxygenated blood to the heart. So these are the only veins, the pulmonary veins. We talked about the heart structures earlier, or we will a little bit later as we talk about EKGs. We've got 4 valves that serve to keep the blood flowing in the forward direction. The cusps of the mitral and tricuspid valves are attached to thin strands of fibrous tissue termed chordae tendineae. And those are these structures right here. And the AV valves, or the atrioventricular valves, are the only valves that have chordae tendineae. The aortic and pulmonic valves do not. The chordae are anchored in papillary muscle of the ventricles, and this support system prevents eversion of the leaflets into the atria during ventricular contraction. The pulmonic and aortic valves, also known as semilunar valves, prevent blood from regurgitating into the ventricles at the end of each ventricular contraction. A little bit more about your valves. We have your mitral valve, which is right here, and that divides the left atrium from the right or the left atrium from the left ventricle, and then we have the tricuspid, which is over on the right, and that divides the right atrium from the right ventricle. The chordae tendineae that we pointed out earlier, the papillary muscle will surround those valves, and then we also have the pulmonic valve, which is right here, and the aortic valve, which is right there. And this is also located in your textbook. Coronary circulation, the biggest ones that I really want you to know are, of course, the vena cava, the superior and inferior, your aorta, which is up here, and then there's three major vessels that you should know. You should know the left anterior descending, which is here. You should know the circumflex, which is also part of the left coronary artery. And the left anterior descending goes down this way from the left coronary artery, and the circumflex goes this way, and then around to the back side of the heart and down. Whereas the right coronary artery goes at the top of the right part of the heart and then to the back side of the heart. We talked about the conduction system, or we will talk about the conduction system with EKGs. Remember that from your anatomy and physiology, your SA node is the primary pacemaker of the heart, goes through the three internodal pathways to the AV node. It goes through the bundle of His, and then we separate into the left and right bundles, and then these little chicken feet things are called Purkinje fibers, and that is the end of the conduction system. And this occurs every single time. This is the electrical system, so this is what generates or stimulates the heart muscle to respond. So systole is the contraction of the heart, and diastole is the relaxation. Your stroke volume is the amount of blood ejected with each heartbeat. Depolarization triggers activity. So that triggers systole to make the myocardium contract, and that results in the ejection of blood from the ventricles. Relaxation, again, is diastole, and that allows for filling of the ventricles. And then again, stroke volume is the amount of blood that's ejected with each heartbeat. Your cardiac output is the amount of blood that is pumped from each ventricle in 1 minute. Normal is 4 to 8 liters per minute. Cardiac index is the cardiac output divided by the body surface area, and normal cardiac index, or CI, is 2.8 to 4.2 liters per minute per meter squared. Numerous factors can affect either the heart rate or the stroke volume, and thus the cardiac output. The heart rate, which is controlled primarily by the autonomic nervous system, can reach as high as 180 beats per minute for short periods without harmful effects, unless you're exercising, and then it can be in the 200s, but that's depending on the conditioning of your heart. The factors affecting the stroke volume are preload, contractility, and afterload. Increasing preload, contractility, and afterload increases the workload of the heart muscle, and that's going to result in an increased oxygen demand. The volume of blood in the ventricles at the end of diastole before the next contraction is called preload. Preload determines the amount of stretch placed on the myocardial fibers. Preload can be increased due to the number of conditions such as aortic diseases and hypervolemia. Contractility can be increased by epinephrine and norepinephrine released by the sympathetic nervous system. Increasing contractility raises the stroke volume by increasing ventricular emptying. Afterload is the peripheral resistance against which the left ventricle must pump. Afterload is affected by the size of the ventricle, wall tension, and arterial blood pressure. If the arterial blood pressure is elevated, the ventricles will meet increased resistance to ejection of the blood, increasing the work demand, and also increasing your O2 demand. Eventually, this results in ventricular hypertrophy or enlargement of the heart muscle without an increase in cardiac output or the size of the chambers. An additional way to understand is if we have preload, the volume of stretching of the ventricles at the end of diastole. Frank-Starling's law, increased stretch equals increased force of contraction. Hypertension, aortic valve disease, and hypervolemia will have an effect on this. And again, the contractility, we talked about that being stimulated by the sympathetic nervous system, and your afterload is basically how much pressure has to be overcome to get the blood from the heart to the vessels. So increased blood pressure leads to increased resistance, which leads to increased workload and leads to hypertrophy or stretching of that heart muscle. Question time. A patient is receiving a drug that decreases afterload. To evaluate the patient's response to the drug, what is most important for the nurse to assess? Heart rate, lung sounds, blood pressure, or jugular venous distension? And the answer is C. Afterload is affected by the size of the ventricle, wall tension, and arterial blood pressure. The structures and the functions of the cardiovascular system include the autonomic nervous system, which consists of the sympathetic nervous system and the parasympathetic, so something that starts it up and something that slows it down. Stimulation of the sympathetic nervous system increases the heart rate, speed of impulse conduction through the AV node, and force of atrial and ventricular contractions. Additionally, stimulation of alpha, which is in the periphery adrenergic receptors in the vascular smooth muscle, results in vasoconstriction, increasing the blood pressure as well. In contrast, stimulation of the parasympathetic system, which is mediated by the vagus nerve, will slow heart rate by decreasing the impulse from the SA node and thus conduction through the AV node. The baroreceptors are in the aortic arch and the carotid sinus at the origin of the internal carotid artery. They're sensitive to stretch or pressure within the arterial system. Stimulation of these receptors, like volume overload, sends information to the vasomotor center of the brainstem. This results in temporary inhibition of the sympathetic nervous system and enhancement of the parasympathetic influence. What this is going to do is cause a decreased heart rate and peripheral vasodilatation. Decreased arterial pressure causes the opposite effect. Your chemoreceptors are in the aortic and carotid bodies and the medulla. They are capable of causing changes in respiratory rate and blood pressure in response to increased arterial CO2, which would be hypercapnia, and to a lesser degree, decreased plasma pH or acidosis, and arterial O2 pressure, hypoxia. When the chemoreceptors in the medulla are triggered, they stimulate the vasomotor center to increase the blood pressure. The arterial blood pressure is a measure of the pressure exerted by blood against the walls of the arterial system. And we also have some calculation that you'll probably want to remember that, your blood pressure is comprised of cardiac output times the systemic vascular resistance. The systolic blood pressure is the peak pressure exerted against the arteries when the heart contracts. The diastolic blood pressure is the residual pressure in the arterial system during ventricular relaxation or filling, and your blood pressure is usually expressed as a ratio of the systolic to the diastolic pressure. The two main factors influencing blood pressure are cardiac output and systemic vascular resistance, or SVR. SVR is the force opposing the movement of blood. This force is created primarily in small arteries and arterioles. Normal blood pressure is systolic blood pressure less than or equal to 120 and diastolic less than or equal to 80. The ability of the cardiovascular system to alter cardiac output in response to many situations in health and illness are based on exercise, stress, and hypovolemia. Pulse pressure is the difference between systolic and diastolic blood pressures. It's normally about 1/3 of the systolic blood pressure. If the BP is 120 over 80, the pulse pressure is 40. So basically, you need to remember what this pulse pressure is, because if it's too high, the heart is not relaxing enough, and if it's too low, then that means that the heart is relaxing too much. We call that a boggy heart. An increased pulse pressure may occur during exercise or in individuals with atherosclerosis of the larger arteries as a result of increased systolic blood pressure. Decreased pulse pressure may be found in heart failure or hypovolemia. Very important that you guys know mean arterial pressure. You will be expected to determine what mean arterial pressure is based on your systolic and diastolic pressures. This refers to the average pressure within the arterial system that's felt by organs in the body. It's not the average of the diastolic and systolic blood pressures because the length of diastole exceeds that of systole at normal heart rates. Your MAP, or mean arterial pressure, is calculated in a couple of different ways. One of the easiest ones is to take your systolic blood pressure plus 2 times the diastolic blood pressure, add those together, and then divide by 3. A person with a blood pressure of 120/60 has an estimated MAP of 80. A MAP greater than 60 is needed to adequately perfuse and sustain the vital organs of an average person under most conditions. When the MAP falls below this number for a period of time, vital organs are underperfused and become ischemic. We also want to consider some gerontology facts. With the autonomic nervous system, the effect of the heart is based on the sympathetic stimulation increases with heart rate, speed of impulse through the AV node, and the force of contractions, as well as beta adrenergic receptors. The parasympathetic stimulation slows. You're going to have heart rate, impulse conduction from SA to AV node, and the vagus nerve. The effects on the blood vessels, as they age, they get hardened. So it's usually your older patients will have a higher blood pressure than the 120/80. Sympathetic stimulation of alpha adrenergic receptors in the periphery causes vasoconstriction, and decreased stimulation causes vasodilatation. Age-related changes, increased collagen and decreased elastin lead to myocardial hypertrophy. Decreased response to stress and exercise equals slower recovery heart rates, stroke volume, and cardiac output. Heart valves become thick and stiff, and so they can develop murmurs. There's a number of pacemaker cells that will decrease, and that can cause dysrhythmias and heart blocks. Decreased number and function of the beta adrenergic receptors means a decreased stress response and sensitivity to beta adrenergic agonists. Blood vessels thicken and become less elastic, which equals increase in systolic blood pressure and decrease or no change in diastolic. Incompetent venous valves means they're going to have dependent edema. Or they can also have orthostatic hypotension, postprandial hypotension, which means an increased risk of falls, and kyphosis, or the bending over and looking like they have a hump at their back. When cells are injured, they release their contents. This includes enzymes and other proteins into the circulation. These biomarkers are useful in the diagnosis of acute coronary syndrome. Cardiac-specific troponin is the gold standard for myocardial infarction. This is a heart muscle protein released into the circulation after injury or infarction. We have 2 types. We have cardiac-specific troponin, which is a CTNT, and a cardiac-specific troponin I, or CNI, are specific to the heart muscle. Normally the level in the blood is very low, so a rise in a level is diagnostic of the myocardial infarction or injury. Both are detectable, both troponins are detectable within hours, on the average of 4 to 6 hours of the MI or injury. They peak at 10 to 24 hours and can be detected for up to 10 to 14 days. Troponin is the biomarker of choice in the diagnosis of acute coronary syndrome. High-sensitivity troponin assays may provide even earlier detection of a cardiac event. Creatine kinase enzymes are found in a variety of organs and tissues and occur as 3 isozymes. These are specific to skeletal muscle, CKMM, brain and nervous tissue is CKBB, and heart is CKMB. CKMB rise is specific for MI or injury. Levels begin to increase 3 to 6 hours after symptom onset, peak in 12 to 24 hours, and return to baseline within 12 to 48 hours after the myocardial infarction. So this is one reason why you may see a CKMB being drawn, because if the patient is reinfarcting, it'll be noted with the fall, but then the rise again of the CKMB, whereas the troponin stays high for 10 to 14 days. The peak level and return to normal can be delayed in a patient with a large MI. Levels drop more rapidly in patients who are quickly and successfully treated for an MI. Copeptin is a substitute marker for arginine vasopressin, or AVP, and it's an additional diagnostic test that can be used for patients presenting with manifestations of acute coronary syndrome. In patients with an acute MI, it can be detected immediately. A combination of troponin and copeptin provide increased sensitivity for diagnosing an acute MI. Myoglobin is a low molecular weight heme protein found in the heart and skeletal muscle. Myoglobin elevation is a sensitive indicator of very early myocardial injury, but it lacks specificity, or it's not specific enough for an MI. Its usefulness in diagnosing MI is limited. The correct interpretation of diagnostic tests requires consideration of the time from the onset of symptoms with the time of the expected presence and elevation of the biomarkers. Additional data, such as patient symptoms, history, and EKG changes, complete the diagnostic picture for the patient with a suspected acute coronary syndrome. Additional blood studies that we can do are the cardiac natriuretic peptide markers. There are 3 of them. The atrionatriuretic peptide, or ANP, from the atrium, B-type natriuretic peptide, BNP, from the ventricles, and C-type from the endothelial and renal epithelial cells. BNP is a marker of choice for distinguishing a cardiac or respiratory cause of dyspnea. N-terminal probrain natriuretic peptide, or NT-proBNP, is also secreted in the ventricles and is more sensitive but less specific than BNP as a diagnostic marker of heart failure. When diastolic blood pressure increases, like in heart failure, BNP and NT-proBNP are released and increase the excretion of sodium into the urine. So if you are thinking about what your BNP is, if it's greater than 100, that would be considered to be elevated. If it's less than that, they can still start to show signs of congestive heart failure, but you'll definitely have very high numbers when they have been suffering and not treated or not taking their medications appropriately for their congestive heart failure. A patient arrives at an urgent care after experiencing unrelenting substernal and epigastric pain and pressure for about 12 hours. You review lab results with the understanding that at this point in time, a myocardial infarction would be indicated by peak levels of troponin T, homocysteine, creatine kinase, myoglobin, or type B natriuretic peptide. And the answer is A. Troponin is a biomarker of choice in the diagnosis of myocardial infarction. Troponin is a myocardial muscle protein released into the circulation after injury and will peak at 10 to 24 hours. We're going to talk about diagnostic studies now. The echocardiogram uses ultrasound waves to record the movement of the structures of the heart in the normal heart. The waves directed at the heart are reflected back in typical patterns. A contrast echocardiography involves the addition of IV contrast agent, like an agitated saline, to assist in defining the images, especially in technically difficult patients, for example, if they're obese. The echocardiogram provides information about the abnormalities of the valvular structures and motion, the heart chamber size and contents, the ventricular and septal motion and thickness, the pericardial sac, and the ascending aorta. The ejection fraction, or the percentage of end diastolic blood volume that is ejected during systole, can also be measured. The EF provides information about the function of the left ventricle during systole. Your patient may have a stress echocardiography, a combination of treadmill test or pharmacological test, and ultrasound images to evaluate the wall motion abnormalities. This test combines the information from a stress test with the information from an echo. For those individuals that are not able to exercise, we can give them IV drugs such as Wtrex or dobutamine or persantine to produce pharmacologic stress on the heart while the patient is at rest. We can also have a TEE, which is the transesophageal echocardiography, and that provides more precise echo signs of the heart than surface 2D echocardiography by removing the interference from the chest wall and the lungs. The TEE uses the flexible endoscope with an ultrasound transducer in the tip for imaging the heart and great vessels. This scope is passed into the esophagus to the level of the heart, and then they use an M-mode 2D Doppler and color flow imaging to get the results. The TEE is contraindicated if the patient has a history of esophageal disorders, dysphagia, radiation therapy to the chest wall. They may require sedation during the TEE as well. We can also do an echocardiogram, resting 12-lead EKG, ambulatory ECG monitoring, or the Holter monitor, exercise or stress testing. We can also do event monitor or loop recorder. This is external, and the electrodes are worn for a month, activated by patients when symptoms occur, and that may be over before they're recorded, so they don't catch everything. We could also do something that's internal to monitor, and this is for serious and frequent dysrhythmias, continuous monitor when symptoms occur or when the heart rate increases or decreases from the set rate. A cardiac cath is a common outpatient procedure. It provides information about coronary artery disease, coronary spasm, congenital and valvular heart disease, and ventricular function. The cardiac catheterization is also used to measure intracardiac pressures and O2 levels, as well as cardiac output and ejection fraction. With injection of the contrast media and fluoroscopy, the coronary arteries can be seen, the chamber of the heart can be outlined, and the wall motion can be observed. During the cardiac cath, it's done by inserting a radiopaque catheter into the right or left side of the heart. From the right side of the heart, a catheter is inserted through the arm vein, either the basilic or the cephalic, or the leg vein, the femoral. Pressures are recorded as the catheter is moved into the vena cava, right atrium, right ventricle, and pulmonary artery. The catheter is then moved until it is wedged or lodged in that position. This blocks the blood flow and the pressure from the right side of the heart and looks ahead through the pulmonary capillary bed to the pressure in the left side of the heart. So that's called the pulmonary artery occlusive pressure. This pressure, or wedge pressure, this pressure assesses the function of the left side of the heart. The left heart catheterization is done by inserting a catheter into the femoral or brachial artery. The catheter is passed in a retrograde manner up to the aorta, across the aortic valve, and into the left ventricle. Coronary angiography is done with a left-sided heart cath, and the catheter is positioned in the origin of the coronary arteries, and contrast medium is injected into the arteries. Patients often feel a temporary flushed sensation with the dye injection. The images identify the location and severity of any coronary blockages. Complications of cardiac catheterization include bleeding or hematoma at the puncture site, allergic reaction to the contrast media, looping or kinking of the catheter, infection, thrombus formation, aortic dissection, dysrhythmias, MI, stroke, and puncture of the ventricles, cardiac septum, or lung tissue. But again, if what they are gaining is more important, so a lot of times they will do it and determine that it's a better situation. If the patient is unhealthy enough to go through a cardiac catheterization, then they will have to either treat them with medicine to minimize the symptom. Okay, this is a normal left coronary artery angiogram. It shows a normal left coronary and circumflex artery. When you have a patient that's going for a cardiac cath, again, we talked about the complications. To manage these, you need to have your baseline assessment. Compare that to the pre-procedure and note any hypotension or hypertension signs of pulmonary embolus. Assess the neurovascular status of the extremity. Compression devices over the arterial site for hemostasis. We want to look for hematoma and bleeding every 15 minutes for 1 hour, and then per agency policy. Bed rest is ordered. We're going to have them on the EKG monitor. We're going to monitor their chest pain, monitor their IV and oral fluid intake and urine output, and educate them regarding discharge instructions and their activity limits, which are minimal. The most concern is within the first 24-48 hours. A patient returns from the cardiac observation area following a cardiac catheterization with a coronary angiography. Which assessment would require immediate action by the nurse? Pedal pulses are 2+ bilaterally, apical pulse is 54 beats a minute, mean arterial pressure is 72, and ST segment elevation develops on the EKG. The answer is D. ST segment elevation on an EKG indicates myocardial ischemia or injury with partial or total occlusion of the coronary artery. This assessment finding requires immediate action, and actions would include assessment for chest pain, 12-lead EKG, administration of nitroglycerin or morphine, notification of the healthcare provider, and if you look at all of the rest, all of those are good signs, not bad signs. ST segment elevation is never a good sign. Atherosclerosis is a blood vessel disorder. It begins as soft deposits of fat that harden with age, and it's referred to as hardening of the arteries. CAD is profound effect on perfusion, which is coronary artery disease. The perfusion depends on the heart's ability to generate enough cardiac output to distribute blood to all body tissues. CAD negatively affects cardiac function, impaired cardiac output, and decreased perfusion. Atherosclerosis is a major cause of CAD and is characterized by lipid deposits within the intima of the artery. Endothelial injury and inflammation play a major role in the development. Cardiovascular disease, or CVD, is a major cause of death in the United States. Coronary artery disease is the most common type of CVD. Coronary artery disease, or CAD, was an underlying cause of death in about 1 out of every 7 deaths in 2014. And according to the World Health Organization, there were 7.4 million deaths from CAD in 2015, and it's only going on the rise. Patients with CAD may be asymptomatic or develop chronic stable angina, chest pain, and may evolve to more serious conditions of unstable angina and myocardial infarction, which are referred to as acute coronary syndrome. Conceptually, CAD has a profound effect on perfusion. The process of perfusion is based on the heart's ability to generate enough cardiac output to distribute blood to all body tissues. CAD negatively affects cardiac function, resulting in impaired cardiac output and decreased perfusion. And this chapter discusses the care of patients with CAD, chronic stable angina, acute coronary syndrome, and measures to promote optimal perfusion. A fatty streak is the earliest lesion, lipid-filled smooth muscle cells that appear yellow, starts at approximately 20 years of age and increase as the patient ages. Treatment to low-density lipoproteins may slow the process. A fibrous plaque is the beginning of the progressive change in endothelium at approximately 30 years of age. LDLs and growth factors stimulate smooth muscle proliferation and arterial wall thickening. Cholesterol and other lipids move into the intima. Collagen covers and forms grayish, whitish fibrous plaque with smooth or rough, jagged edges, and narrowed vessel lumen reduces the distal blood flow. Just a little bit on hypertension. Hypertension or high blood pressure is one of the most important modifiable risk factors that can lead to the development of cardiovascular disease. As blood pressure increases, so does the risk of myocardial infarction, heart failure, stroke, and renal disease. Heart disease, often directly related to hypertension, accounts for 23.7% of all deaths each year in the U.S. Healthy People 2020 lists the number of adults with hypertension whose blood pressure is under control as one of the 26 high priority leading health indicators for the coming decade. The National Health and Nutrition Examination Survey tracks prevention, treatment, and control of hypertension. Data from them show that 83% of people 20 years of age or older with hypertension were aware that they had high blood pressure. Of these, 76% were being treated. Of those aware of their hypertension, 48% did not currently have their BP well controlled. The American College of Cardiology Foundation and the Heart Association provide performance measurements for hypertension management that address not only treatment, but also control of blood pressure to target goals. Target goals have been updated with new information from the evidence-based guidelines for the management of high blood pressure in adults report from the 8th Joint National Committee. Target goals take into consideration both age and comorbidities, which recommend treatment options. The national guidelines are designed to apply to all racial and ethnic groups. However, certain groups have a higher incidence of risk factors, and we'll talk about those in a little bit. So we have factors that influence our blood pressure, which is a product of cardiac output and systemic vascular resistance. What affects our cardiac output is the heart rate, contractility, and conductivity, as well as renin-angiotensin, aldosterone system, and the natriuretic peptides. Our SVR, systemic vascular resistance, is affected by neurohormonal factors, such as our vasoconstrictors that are in our body normally, the angiotensin, as well as your norepinephrine. Sympathetic nervous systems, the alpha 1 and alpha 2 adrenergic receptors, which cause vasoconstriction when they're stimulated, and the beta 2 adrenergic receptors, which cause vasodilatation. The local regulators, also the vasodilators, are prostaglandins, nitric acid or oxide, and vasoconstrictors are endothelin. Long-term mechanisms include renal and hormonal processes that regulate arterial resistance and blood volume. In a healthy person, these regulatory mechanisms function in response to the demands of the body. Each mechanism is more fully described as we go on with this presentation. As you can see from this slide, the endocrine system has stimulation of the sympathetic nervous system, resulting in a release of epinephrine along with a small fraction of norepinephrine by the adrenal medulla. Epinephrine increases the cardiac output by increasing the heart rate and myocardial contractility. Epi activates beta 2 adrenergic receptors in the peripheral arterioles of the skeletal muscle, causing vasodilatation. In peripheral arterioles with only alpha 1 adrenergic receptors, they are in the skin and the kidneys, epi causes vasoconstriction. A2 stimulates the adrenal cortex to release aldosterone. Aldosterone stimulates the kidneys to retain sodium and water, and this increases blood volume and cardiac output. An increased blood sodium and osmolarity level stimulates the release of ADH from the posterior pituitary gland, which increases the ECF, or the external circulating fluid, by promoting the reabsorption of water in the distal and collecting tubules of the kidneys. The resulting increase in blood volume causes an increase in cardiac output and blood pressure. Hypertension is defined as a persistent systolic blood pressure of 140 millimeters mercury or more, diastolic blood pressure of 90 millimeters mercury or more, or current use of antihypertensive medication. Pre-hypertension is defined as systolic blood pressure of 120 to 139 millimeters per mercury, or diastolic of 80 to 89 millimeters per mercury. Isolated systolic hypertension, or ISH, is defined as an average systolic blood pressure of 140 millimeters of mercury or more, coupled with an average diastolic blood pressure of less than 90. Systolic increases with age, and diastolic rises until approximately age 55 and then declines. The control of the ISH decreases the incidence of stroke, heart failure, and death. and blood pressure classification is based on the confirmation of office blood pressure readings with ambulatory blood pressure monitoring. The nurse determines that the patient has stage 2 hypertension when the patient's average blood pressure is 150/96, 155/88, 172/92, 160/110, or 182/106. And the answer is, and because it's a select all apply, it's C, D, and E. Stage 2 hypertension is diagnosed when systolic blood pressure is greater than or equal to 160, or diastolic blood pressure is greater than or equal to 100. While performing blood pressure screening at a health fair, the nurse counsels which person is having the greatest risk for developing hypertension. A 56-year-old man whose father died at age 62 from a stroke, a 30-year-old female advertising agent who is unmarried and lives alone, a 68-year-old man who uses herbal remedies to treat his enlarged prostate, a 43-year-old man who travels extensively with his job and exercises only on weekends. And the answer is A. A history with a close blood relative, such as father to son, with hypertension is associated with an increased risk for developing hypertension. Atherosclerosis is the most common cause of cerebral vascular disease, and hypertension is the major risk factor for cerebral atherosclerosis and stroke. The most common complications of hypertension are target organ diseases occurring in the heart, hypertensive heart disease in the brain, cerebral vascular disease in the peripheral vessels, peripheral vascular disease in the kidneys, nephrosclerosis, and in the eyes, retinal damage. These are some examples of what you can do for saturated, monosaturated, and polyunsaturated. So you want to use primarily the ones that are the polyunsaturated and very sparingly the good things that everybody likes to eat, like bacon and eggs and sour cream and butter. A patient's blood pressure has not responded consistently to the prescribed drugs for hypertension. The first cause of this lack of responsiveness the nurse should explore is progressive target organ damage, the possibility of drug interactions, the patient not adhering to therapy, the patient's possible use of recreational drugs. And the answer is C. Side effects of antihypertensive drugs are common and may be severe or undesirable that the patient does not comply with the therapy. A patient takes a blood pressure at a health fair. The nurse identifies that the person is most risk for developing hypertension. A 52-year-old male who smokes and has a parent with hypertension, a 32-year-old female advertising agent who is unmarried and lives alone, a 68-year-old male who uses herbal remedies to treat an enlarged prostate, and a 43-year-old female who travels extensively for work and exercises only on weekends. The answer is A. Again, hypertension is more prevalent in men who are less than 55 years of age. Smoking tobacco greatly increases the risk of cardiovascular disease, and a history of a close family relative, such as parents or siblings with hypertension, is associated with an increased risk for developing hypertension. Other risk factors include increasing age, sedentary lifestyle, and stress. So MP is a 58-year-old white male who visits a local health clinic for physical examination. He tells a healthcare provider that he occasionally gets indigestion when he mows the lawn. It goes away in 5 to 10 minutes after he stops and rests. While obtaining a health history, which risk factors for coronary artery disease would you ask him? Based on the presence of these risk factors and report indigestion with activity, what type of angina does MP have? His health history and physical examination revealed the following risk factors for CAD: chronic stable angina, a family history of CAD, he smokes a pack of cigarettes a day, sedentary lifestyle, high-fat diet, and blood pressure 152/94, and his BMI is 30.2. And he is experiencing chronic stable angina at this point. 2 risk factors for coronary artery disease that increase the workload of the heart and increase myocardial oxygen demand are obesity and smokeless tobacco use, hypertension and cigarette smoking, elevated serum lipids and diabetes mellitus, physical inactivity, and elevated homocysteine levels. The answer is B. An elevated blood pressure and cigarette smoking which causes vasoconstriction, increase the rate of atherosclerosis. Atherosclerosis increases the workload of the heart and increases myocardial oxygen demand. An estimated 31.9 million American adults have cholesterol levels greater than or equal to 240. Guidelines for treatment of high cholesterol focus on LDL cholesterol. A complete lipid panel is recommended every 5 years, beginning at age 20. Guidelines recommended the following groups of people receive statin therapy: patients with known CVD, patients with primary elevations of LDL cholesterol greater than or equal to 190, familial high cholesterol, patients with between 40 and 75 years with diabetes and LDL cholesterol levels between 70 and 189, and patients between 40 and 75 with LDL cholesterol levels between 70 and 189 and a 10-year risk of CVD of at least 7.5%. Treatment also includes weight loss, decreased dietary fat and cholesterol intake, and increased physical activity. Serum lipid levels should be reassessed after 6 weeks of therapy. If they are still elevated, we need additional dietary options and drug therapy may be considered. Drugs that restrict lipoprotein production are statins, and they are the most widely used lipid-lowering drugs. These drugs inhibit the synthesis of cholesterol in the liver. An unexplained result of the inhibition of cholesterol synthesis is an increase in hepatic LDL receptors, but the liver is able to remove more LDLs from the blood. In addition, statins produce a small increase in HDLs and lower CRP levels. Serious adverse effects of these drugs are rare and include liver damage and myopathy that can progress to rhabdomyolysis, or the breakdown of skeletal muscle. Liver enzymes are initially monitored and rechecked with any increase in dosage. Unless it's contraindicated, such as a history of GI bleed, low-dose aspirin, or 81 milligrams a day, is recommended for most people at risk for CAD. Current recommendations include low-dose aspirin for men over 45 and high-risk women, those with a calculated 10-year CAD risk of more than 20%. For high-risk women who are intolerant of aspirin, we can try clopidogrel or Plavix. In healthy women 65 years or older, aspirin therapy may be considered if blood pressure controlled and the benefit of MI prevention outweighs the risk of GI bleed or hemorrhagic stroke. So moving on to angina or angina. This is a chronic and progressive symptom and disease. What happens is our O2 demand is greater than our O2 supply, and that will lead to myocardial ischemia. Angina is a clinical manifestation. It occurs when arteries are blocked 70% or more, or 50% or more for the left main coronary artery. Chronic stable angina refers to chest pain that occurs intermittently over a long period of time with a similar pattern of onset, duration, and intensity of symptoms. It is often provoked by physical exertion, stress, or emotional upset. When asked, some patients may deny feeling pain but describe a pressure, heaviness, or discomfort in the chest. This discomfort is often described as a squeezing, heavy, tight, or suffocating sensation. It can be associated with other symptoms such as dyspnea or fatigue. Chronic angina usually does not change with position or breathing and is rarely described as sharp or stabbing. The pain of chronic stable angina usually lasts for only a few minutes and commonly subsides when the precipitating factor is resolved, like they rest, they calm down, they use nitroglycerin. Pain at rest is usual and often a symptom of unstable angina. A 12-lead EKG often shows ST segment depression and or T-wave inversion, which can indicate ischemia. But remember, ischemia is reversible. The EKG will return to baseline when the pain is relieved. Chronic stable angina is controlled with drugs on an outpatient basis because chronic stable angina is often predictable. Drugs are timed to provide peak effects during the time of day when angina is likely to occur. For example, if angina occurs when rising, the patient can take the drug as soon as awakening and wait 30 minutes to 1 hour before engaging in activity. So what we're going to ask is the PQRST. What is a precipitating event? What is the quality of pain? What is the region located and radiation of pain? What is the severity of pain? What is the timing? When did it happen? Have you had this before? How long did it last? They can deny pain, have pressure, heaviness, or discomfort in chest, and this can be accompanied again by dyspnea, fatigue, and it doesn't make any difference if they change their position or their breathing. So these are the different places that an individual can experience angina. Again, the first one, he's got it in the middle of his chest, in his neck, on both arms, or maybe only on one, which is the one that is to his right. It could also be epigastric, or epigastric radiating to the neck, jaw, and arms, and it can also be intrascapular. So types of angina, we can have chronic stable angina, which the duration of the pain is a few minutes, and then it subsides when precipitating factors are resolved. Rest, calming down, nitroglycerin generally will take the pain away, but we may see ischemic changes on the 12 lead, which again are ST segment depression or T-wave inversion. Silent ischemia refers to ischemia that occurs in the absence of any subjective symptoms. Patients with diabetes have an increased prevalence of silent ischemia, and this is most likely due to diabetic neuropathy affecting the nerves that innervate the cardiovascular system. Silent ischemia is documented by EKG changes. The duration of the pain, again, is a few minutes, and it usually subsides when the precipitating events go away. Prince-Meadows angina, or variant angina, is a rare form of angina that often occurs at rest and not with increased physical demand. There's a strong contraction or a spasm of smooth muscle in the coronary artery results from an increased intracellular calcium. Factors causing coronary artery spasm include increased myocardial oxygen demand and increased levels of certain substances like tobacco smoke, alcohol, and amphetamines. When the spasm occurs, the patient experiences angina and transient ST segment elevation. The pain can occur during rapid eye movement or REM sleep when the myocardial oxygen consumption increases or when exposed to cold temperatures. The pain can also be relieved by moderate exercise with sublingual nitroglycerin, or it may disappear spontaneously. Cyclic short bursts of pain at any usual time each day may occur with this type of angina, and calcium channel blockers and or nitrates are used to control the pain, as well as stopping any offending substances. What diagnostic testing would you expect the healthcare provider to order for our patient MP? While awaiting diagnostic testing for MP, what drug would you expect the healthcare provider to prescribe for MP to use if he develops the indigestion pain the next time he mows the lawn? So diagnostic studies include a 12-lead. Lab studies are cardiac biomarkers, lipid profile, C-reactive protein test for inflammation, chest x-ray, echo, exercise stress test, electron beam computed tomography, coronary computed tomography angiography, and sublingual nitroglycerin. Our goal with chronic stable angina is to decrease O2 demand and or increase O2 supply. We can also use nitrates, angiotensin converting enzymes or ACE inhibitors, beta blockers, calcium channel blockers, but the additional goals are definitely to decrease pain. Or relieve pain. Immediate and appropriate treatment, preservation of heart muscle if the MI is suspected, effective coping with illness-associated anxiety, participation in rehab, and reduction of the risk factors. Acute care with patient with angina would be to position them upright, apply oxygen, assess their vitals, heart and breath sounds, continuous EKG, pain relief with nitroglycerin or IV opioids like morphine, obtain cardiac biomarkers, get a chest x-ray, provide support, and reduce their anxiety. For ambulatory care, patient education, we need to teach them about CAD and angina, what are the precipitating factors and how to avoid them and control them, reducing the risk factors with diet and physical activity, medications that they may be on, and psychosocial support. We can also give nitroglycerin, like I had said, to emphasize that a little bit more. We would want to give nitroglycerin if they're in their home. They can take it, and if their pain is not better in 5 minutes, then they can take another one up to a maximum of 3 doses. But what we have to consider is, when do we call the ambulance? If normally they can take 1 nitro and it takes their pain away, then we wouldn't call an ambulance. But if the first one does not take the pain away and they have to take another nitro, then you should call the ambulance, because now it's going from chronic to unstable. Long-acting nitrates reduce angina incidence. Their main side effect, though, is headache, orthostatic hypotension, which some patients find to be very disconcerting. Methods of administration are oral, ointment, such as paste, and transdermal controlled release nitroglycerin. So they will have a patch on for 24 hours. We think MONA, which is morphine, oxygen nitrates, and aspirin, but we're going to give ONAM, oxygen nitrates, aspirin, and morphine. We're going to use whichever mode is appropriate for the oxygen. The short-acting nitrates dilate the peripheral and coronary arteries and collateral vessels. Sublingual nitroglycerin, we're going to give 1 tablet or 1 to 2 metered sprays. Again, relief should be in 5 minutes, and it should last 30 to 40 minutes. We can repeat it every 5 minutes for 3 doses. If we don't get relief after we have normally received relief, that's when EMS needs to be notified. It can cause headache, dizziness, flushing, orthostatic hypotension. We need to make sure that the patient knows that the nitroglycerin has to be stored in the original bottle and not be exposed to moisture or light, and also that it doesn't expire. And it is a prophylactic use. We can also give aspirin, and normally you're going to give 325 milligrams. This is not the prophylactic 81 milligrams, because now we are having heart problems. And then morphine, in the hospital situation or in the ambulance, we can give 1 to 2 milligrams every 3 to 5 minutes. In addition, we can give ACE inhibitors or angiotensin receptive blockers, or ARBs, for vasodilatation and reduced blood volume, and to prevent or reverse ventricular remodeling. Beta blockers for reduced myocardial contractility, heart rate, systemic vascular resistance, and blood pressure. The side effects of beta blockers include bradycardia, hypotension, wheezing, GI effects, weight gain, depression, fatigue, and sexual dysfunction. Beta blockers are contraindicated with severe bradycardia and acute decompensated heart failure. Cautious use is for patients with asthma and diabetes. Calcium channel blockers can also be given for systemic vasodilatation with reduced systemic vascular resistance, reduced myocardial contractility, coronary vasodilatation, and reduced heart rate. Side effects include fatigue, headache, dizziness, flushing, peripheral edema. So diagnostic studies we can expect for your patient, again, are chest x-ray, 12 lead, lab studies, echo, exercise stress test, and the EBCT and CCTA. The EBCT is that electron beam computed tomography, and that scan locates and measures the coronary calcification. The CCTA is a coronary computed tomography angiography, and that they will use IV contrast and radiation, and this can detect calcified and non-calcified plaques in the artery, as well as other heart conditions. Limitations of using this are patients with rapid heart rates, more than 90 beats per minute, extensive coronary artery calcifications, obesity, and a history of prior coronary artery stent. Patients who are allergic to IV contrast dye must be premedicated with corticosteroids, and patients with chronic kidney disease need hydration pre and post procedure. A baseline serum creatinine level should be obtained, as the IV dye contrast can worsen renal function. So our patient develops chest pain and ST segment depression during an exercise stress test. What additional testing do you think that we're going to have for this patient? Again, the echo, exercise stress test, EBCT, CCTA, and cardiac cath. For patients with increasing angina, a cardiac cath is ordered. They're going to use radiation and IV contrast dye to provide images of the coronary circulation and identify the location and severity of the blockage. If the patient is allergic to the dye, we're going to premedicate. If the coronary blockage is amenable to treatment, coronary revascularization with an elective percutaneous coronary intervention or a PCI may be recommended. This could be an angioplasty or the PTCA, and then they will have a stent placed as well intracoronary. And they're usually placed along with the balloon angioplasty. And this is what the placement of a coronary artery stent looks like. It goes in between the plaque buildup, the balloon is expanded, the balloon deflates, and then the stent is left behind. There are two types of stents, bare metal stents and drug-eluting stents. Drug-eluting stents are coated with a drug to reduce the risk of overgrowth of the intimal lining. This is a primary cause of an in-stent restenosis, and following the placement, dual antiplatelet drugs are taken to prevent thrombus formation within the stent, or a stent thrombus, for a minimum of 12 months or longer, and the duration of dual antiplatelet drugs for patients with BMS is a minimum of 1 month, but ideally 1 full year after the PCI, or the percutaneous coronary intervention. Stent placement procedure and post-procedure drugs are used to prevent platelet aggregation and acute stent thrombosis. So during the PCI, they'll get unfractionated heparin or low molecular weight heparin and a direct thrombin inhibitor or glycoprotein 2B3A inhibitor. After the PCI, then the dual antiplatelet therapy would be aspirin and clopidogrel. This is a pre-PCI on the left. You can see where the narrowing is from the arrows, and then after they have done the PTCA and inserted the stents, that vessel is wide open. Our patient undergoes a cardiac cath. 90% occlusion of his right coronary artery is found. He has a balloon angioplasty and stent placement, discharge teaching related to the CAD and necessary lifestyle changes such as diet and exercise is provided, and he is scheduled for a follow-up with his healthcare provider. 6 months later, he comes back into the ED complaining of severe immobilizing chest pain radiating down his left arm. He admits to not following his healthcare provider's advice related to diet and exercise. He states that he thought that the stent opened up his arteries and cured his CAD. The ED physician expects acute coronary syndrome. What is this diagnosis? Prolonged ischemia, not immediately reversible, includes non-ST elevation acute coronary syndrome, unstable angina, and non-ST segment elevation myocardial infarction, or NSTEMI, or an ST segment elevated myocardial infarction, which is STEMI. Coronary artery disease can be divided into chronic stable or acute coronary syndrome, which then is divided into ST segment elevation MI or STEMI, or unstable angina or non-STEMI. When ischemia is prolonged and not immediately reversible, that is acute coronary syndrome, and this includes a spectrum of unstable angina, STEMI, and non-STEMI. When patients first present with chest pain, ST elevation on a 12-lead EKG are most likely to indicate a STEMI. The EKG should always be compared to a previous EKG whenever possible. If patients with chest pain who do not show ST segment elevation or ST T-wave changes on the EKG, it's difficult to distinguish between unstable angina and non-STEMI until we get the cardiac biomarkers. On the cellular level, the heart muscle becomes hypoxic within the first 10 seconds of a total coronary occlusion. Heart cells are deprived of oxygen and glucose needed for aerobic metabolism and contractility. Anaerobic metabolism will begin and lactic acid will accumulate as this progresses. In ischemia conditions, heart cells are viable for approximately 20 minutes. Irreversible heart damage starts after 20 minutes if there's no collateral circulation. Acute coronary syndrome is caused by the decline of one stable atherosclerotic plaque. The frequently stable plaque ruptures, releasing substances into the vessel. This stimulates platelet aggregation and thrombus formation. This area may be partially occluded by a thrombus or totally occluded by a thrombus. If it's partially, that would be non-STEMI. If it is totally occluded by a thrombus, that is a STEMI. What causes a coronary plaque to suddenly become unstable is not well understood, but systemic inflammation, as described earlier, is thought to play a role. Patients with suspected acute coronary syndrome require immediate hospitalization. So they'll have ST segment elevation on a 12 lead, are mostly STEMI, but unstable angina or non-STEMI may not have ST segment depression and or T-wave inversion. Unstable angina is chest pain that is new in onset, occurs at rest, or occurs with increasing frequency, duration, or with less effort than the patient's chronic stable angina pattern. The pain typically lasts 10 minutes or more. We have to do prompt treatment for patients suspected of having unstable angina. This patient with previously diagnosed chronic stable angina will describe a significant change in the pattern. It'll occur with increasing frequency and is easily provoked by minimal or no exertion during sleep or even at rest. Unlike chronic stable angina, unstable angina is unpredictable and must be treated immediately. Despite efforts to increase awareness, women's symptoms continue to be unrecognized as heart-related. These include fatigue, shortness of breath, indigestion, and anxiety. Fatigue is the most prominent symptom. However, all of these symptoms can relate to many different diseases and syndromes. It's because of these reasons that women often present with unstable angina before CAD is diagnosed. New onset, which occurs at rest or with an increase in frequency, duration, or with less effort than chronic stable pattern, and maybe the first clinical sign of CAD. Again, the pain is going to last more than 10 minutes. A myocardial infarction occurs because of abrupt stoppage of blood flow through a coronary artery from a thrombus caused by platelet aggregation. This causes irreversible myocardial cell death and necrosis. Most MIs occur in the setting of pre-existing CAD. When a thrombus develops, blood flow to the heart muscle beyond the blockage stops, resulting in necrosis. A STEMI caused by an occlusive thrombus creates ST segment elevation in EKGs facing the area of the infarction. A STEMI is an emergency situation. In order to limit the infarct size, the artery must be opened within 90 minutes of presentation. This can be done either by a PCI or a thrombolytic fibrolytic therapy. PCI is the preferred treatment and the hospital is capable of performing this. Non-STEMI caused by a non-occlusive thrombus does not cause ST segment elevation on the 12 lead. Patients may or may not develop ST segment T-wave changes in the leads affected by the infarction. Non-STEMI patients do not go to the cath lab emergently, but usually undergo the procedure within 12 to 72 hours if there's no contraindications. Thrombolytic therapy is not indicated for non-STEMI, only STEMI. With either a STEMI or non-STEMI, an echo may show hypokinesis or worsening of myocardial contractility or akinesis. They have no myocardial contractility in the necrotic areas. The degree of left ventricular function depends on the area of the heart involved and the size of the infarction. So this shows you where the blockage is in the LAD, or the left anterior descending. Some of you probably have heard of the widowmaker. A widowmaker basically is an occlusion anywhere up here in the left coronary artery, because if you have one right before this bifurcation, you're going to occlude your circumflex and your total LAD, which is basically the left side and the back side of your heart. The acute MI process evolves over time. The earliest tissue to become ischemic is the subendocardium, the innermost layer of tissue in the heart muscle. If ischemia persists, it takes approximately 4 to 6 hours for the entire thickness of the heart muscle to become necrosed. If the thrombus is not completely blocking the artery, the time to complete necrosis may take as long as 12 hours. You can see from this picture where the areas of necrosis are. That's the white arrow. The scarring from a previous anterior wall myocardial infarction is the black arrow. So that's basically dead tissue. The majority of MIs affect the left ventricle and are usually described based on the location of the damage. Is it anterior, inferior, lateral, septal, or posterior wall? The location of the MI and the EKG changes correlate with the involved coronary artery. So we don't expect you to read 12 leads, just know that that's how we are going to determine if they're having a STEMI or a non-STEMI. In most people, the right coronary artery provides blood to the inferior and posterior walls of the left ventricle. Blockage of the right coronary artery results in an inferior wall and or posterior wall MI. Anterior wall infarctions result from blockages in the left anterior descending. Blockages in the left circumflex artery usually cause lateral left ventricular wall MIs. Damage can occur in more than one location, especially if more than one coronary artery is involved, such as an anterolateral MI. Right ventricular MIs are much less common and treated differently than left ventricular MIs. And right ventricular MIs tend to have more hypotension than left ventricular. Not everyone develops collateral circulation, but if they do have it, the degree of collateral influences the severity of the MI. An individual with a long history of CAD may develop good collateral circulation to provide the area surrounding the infarction site with a blood supply. This is one reason why a younger person may have a more serious first MI than an older person with the same degree of blockage. So the pain can be described as severe, not really by rest, position change, or nitrate administration. It can be a heaviness, pressure, tightness, burning, or constriction. They can also say that it's crushing. It can be substernal or epigastric. It can radiate to any part of the body. Usually occurs in the morning after a night of sleep. It's atypical in women and elderly, and no pain if they have cardiac neuropathy due to their diabetes. So the clinical manifestations of acute coronary syndrome and a myocardial infarction include catecholamine release and stimulation of the sympathetic nervous system. During the initial phase of the MI, the ischemic heart cells release catecholamines like norepinephrine and epinephrine that are normally found in these cells. This results in release of glycogen, diaphoresis, increased heart rate and blood pressure, and vasoconstriction of the peripheral blood vessels. On physical examination, the patient's skin may be ashen, clammy, and cool to touch. As the MI evolves from hours to days, the subendocardium is ischemic first. The entire thickness of the heart muscle necrosis is in 4 to 6 hours. Partial occlusion by thrombus is up to 12 hours. The MI is described by the location, as I said earlier, and the location of an MI and EKG changes correlate with the involved coronary artery. The severity of the MI is influenced by collateral circulation, and again, women are most undertreated and have the worst outcomes. Cardiovascularly, in response to the release of catecholamines, blood pressure and heart rate may initially increase. The blood pressure may drop because later on as a result of decreased cardiac output. If severe enough, this can result in decreased renal perfusion and urine output. They can develop crackles, and that can persist for several hours to several days, suggesting left ventricular dysfunction. They can develop jugular venous distension, hepatic engorgement, and peripheral edema, which may indicate right ventricular dysfunction. Examination may reveal abnormal heart sounds that may seem distant. Other abnormal sounds suggesting left ventricular dysfunction are an S3 and an S4, which are both abnormal. In addition, a loud holosystolic murmur may develop, and this can indicate a ventricular septal defect, papillary muscle rupture, or valve dysfunction. They can also develop nausea and vomiting. These symptoms can result from reflex stimulation of the vomiting center by the severe pain. They can also result from vasovagal reflexes initiated from the area of the infarcted heart muscle. The temperature may increase to 100.4 within the first 24-48 hours, and the temperature elevation may last for as long as 4 to 5 days. This increase in temperature is due to systemic inflammatory process caused by the death of the heart cells. Within 24 hours, the body's response to cell death is the inflammatory process. So leukocytes will infiltrate the area of the cell death. The proteolytic enzymes of the neutrophils and the macrophages begin to remove necrotic tissue by the 4th day. During this time, the necrotic muscle wall is thin. The necrotic zone of a STEMI is identified by EKG changes, such as lowering of the ST segments, T-wave inversion, pathological Q waves, and this will happen within a day or two. At this point, the neutrophils and monocytes have cleared the necrotic debris from the injured area, and the collagen matrix will eventually form scar tissue, and that is laid down at that point. 10 to 14 days after the MI, the new scar tissue is still weak. The heart muscle is vulnerable to increased stress during this time because of the unstable state of the healing heart wall. It is also at this time that the patient's activity level may be increasing, so special caution and assessment are necessary. By 6 weeks after the MI, the scar tissue has replaced necrotic tissue and the injured area is considered healed. Often the scarred area is less compliant than the surrounding area, and this condition may be manifested by abnormal wall motion on an echo or nuclear imaging, left ventricular dysfunction, altered conduction patterns, or heart failure. These changes in the infarcted heart muscle can also cause changes in the unaffected areas. In an attempt to compensate from the damaged muscle, the normal myocardium will hypertrophy and dilate. This process is called ventricular remodeling. Remodeling of the normal myocardium can lead to the development of late heart failure, especially in the patient with atherosclerosis of other coronary arteries and/or anterior wall MI. ACE inhibitors are given to limit ventricular remodeling. Any condition that affects the heart cell sensitivity to nerve impulses, such as ischemia, electrolyte imbalances, sympathetic nervous system stimulants, can cause dysrhythmias that adversely affect the damaged heart muscle. Dysrhythmias are the most common complication after an MI, and they occur in 80 to 90% of patients. Ventricular tachycardia and ventricular fibrillation are the most common cause of death in patients in the pre-hospital period. If a patient survives a cardiac arrest, we are going to initiate a therapeutic hypothermia protocol as soon as possible. Bradycardias, which also include complete heart block, can develop when key areas of the conduction system are destroyed. VTAC or VFib are the most often occur within the first 4 hours after the onset of pain. Premature ventricular contractions, or PVCs, may precede VTAC and VFib, and life-threatening ventricular dysrhythmias must be treated immediately. With reperfusion, it's not uncommon to see PVCs, asymptomatic, non-sustained VTAC, and idioventricular rhythms. These rhythms are not associated with an increased risk of sudden cardiac death and are not treated unless the patient is symptomatic. Heart failure is a complication that occurs when the right or left heart pumping action is reduced. Depending on the severity and extent of the injury, left-sided heart failure occurs initially with the subtle signs such as mild dyspnea, restlessness, agitation, or slight tachycardia. Other signs indicating the onset of left-sided heart failure include pulmonary congestion on chest X-ray, S3, S4, heart sounds on auscultation of the heart, crackles on auscultation of the lungs, paroxysmal nocturnal dyspnea, or PND, or orthopnea. Signs of right-sided heart failure include jugular venous distension, hepatic congestion, or lower extremity edema. The patient can also go into cardiogenic shock, which occurs when the oxygen and nutrients applied to the tissues are inadequate because of severe left ventricular failure, papillary muscle rupture, ventricular septal rupture, left ventricular free wall rupture, or right ventricular infarction. This occurs less often with the early and rapid treatment of STEMI with PCI or thrombolytic therapy. When cardiogenic shock does occur, it is associated with a high death rate. Cardiogenic shock requires aggressive management, and this includes control of dysrhythmias, intra-aortic balloon pump therapy, and support of the contractility with vasoactive drugs. Goals of therapy are to maximize oxygen delivery, reduce oxygen demand, and prevent complications such as acute kidney injury. Papillary muscle dysfunction may occur in the infarcted area if the infarcted area is included or near the papillary muscle that attaches to the mitral valve. Papillary muscle rupture is a rare and life-threatening complication and causes immediate and massive mitral valve regurg with no time for the heart to compensate. Dyspnea, pulmonary edema, and decreased cardiac output result from the backup of blood into the left atrium. This condition aggravates an already damaged left ventricular by reducing cardiac output even further. There is a rapid clinical decline of the patient. And the treatment will include afterload reduction with nipride or nitroprusside and or an intra-aortic balloon pump therapy and immediate cardiac surgery with mitral valve repair or replacement. Left ventricular aneurysm results when the infarcted heart wall is thin and bulges out during contraction. This can develop within a few days, weeks, or months. It's more common with anterior wall MIs. The patient will have a ventricular aneurysm, may experience heart failure, dysrhythmias, and angina. Besides ventricular rupture, which is usually fatal, ventricular aneurysms can hide thrombi that can lead to an embolic stroke. Anticoagulation therapy is recommended for these patients if not contraindicated. A new loud systolic murmur heard in patients with an acute MI may signal ventricular septal wall rupture. Depending on the size of the defected and degree of the right and left ventricular dysfunction, heart failure and cardiogenic shock may occur. The patient must receive emergency repair, either surgically or percutaneously. The defect can quickly expand and lead to hemodynamic compromise. Left ventricular free wall rupture in an emergent clinical situation leads to rapid hemodynamic compromise, and death ensues if not treated immediately. Although this is a rare complication, death rates are high. Free wall rupture is seen more frequently in patients suffering their first MI, especially if they're young, patients with anterior wall MIs, older adults, and women. Pericarditis is an inflammation of visceral, antral, and or parietal pericardium, and it can occur 2 to 3 days after an acute MI. Pericarditis is characterized by mild to severe chest pain that increases with inspiration. This is key when you're trying to differentiate between angina and pericarditis. And the movement of the upper body. Sitting in a forward position often relieves the pain. Assess a patient with suspected pericarditis for the presence of a friction rub over the pericardium. The sound is best heard with the diaphragm of the stethoscope at the mid to lower left sternal border. It may be persistent or intermittent, and fever can also be present. Diagnosis of pericarditis can be made with a serial 12-lead EKG. Typical EKG changes include diffuse ST segment elevations, and this reflects the inflammation of the pericardium. Treatment includes pain relief with high doses of aspirin, 650 milligrams every 4 to 6 hours. So we want to do a detailed health history of pain, risk factors, and health. In primary diagnostic studies used to determine whether a person has unstable angina or an MI include an EKG and serum cardiac biomarkers. The EKG is one of the most primary tools to diagnose STEMI or non-STEMI, and whether possible, it can be compared to a previous EKG. Changes in the QRS, ST, and T wave caused by ischemia infarction can develop slowly or quickly with unstable angina or an MI. The EKG must be read carefully since changes can be absent or subtle at first, and for this reason, serial 12-lead EKGs are done. And it's very important to distinguish STEMI from non-STEMI or unstable angina. Again, STEMI patients usually have a complete coronary occlusion, and patients with non-STEMI have a transient thrombosis or incomplete coronary occlusion. Because the MI is a dynamic process that evolves over time, serial EKGs are done to show the evolution of the ischemia, the injury, infarction, and resolution. Coronary angiography in a patient with the STEMI, it is necessary within the first 90 minutes of presentation, or they need to receive thrombolytic therapy within 30 minutes in agencies without PCI capability. This will open the totally occluded artery and limit the infarction size. A patient with UA with unstable angina or non-STEMI may or may not undergo coronary angiography to evaluate the extent of the disease. Guidelines suggest that it's reasonable to do coronary angiography on stable but high-risk patients with unstable angina or non-STEMI within 12 to 72 hours after presentation. If appropriate, a PCI is performed at this time, and some patients may be treated only with conservative medical management. If they need stress testing, it could be done pharmacologically because they may not be able to physically do that, so they will receive drugs that will actually stimulate and cause the same type of reactions. So we want to identify the priority interventions for MP on his arrival in the ED, because we have to diagnose as quickly as possible, especially if they have acute coronary syndrome, to preserve that heart muscle. So we're going to get a 12 lead and start continuous EKG monitoring. We're going to position him in an upright position unless contraindicated, and initiate oxygen by nasal cannula to keep the oxygen saturation above 93%. We are going to establish an IV, at least one, but many more, probably because of the medications that MP may be receiving. We may give him sublingual nitroglycerin and 162 to 325 milligrams of aspirin, chewable only. High-dose statin, like Lipitor, is started, if not already taken prior to the hospitalization, and the patient may also get morphine to not only relieve the pain, but also dilate the coronary arteries. So his EKG demonstrates significant ST segment elevation. What evidence-based intervention would you expect to prepare MP to undergo within 90 minutes of arrival to the ED? Reperfusion therapy, including emergent PCI, which is preferred, or thrombolytic therapy for STEMI. Ongoing monitoring, he will usually receive ongoing care in a critical care unit or telemetry unit where continuous ECG monitoring is available. Dysrhythmias are treated. Some people may get glycoprotein 2B3A inhibitors, either before catheterization or at the time of PCI. We're going to monitor their vitals, including their pulse ox, frequently during the first hours of admission and closely thereafter. Maintain blood rest and limitation of activity for 12 to 24 hours with a gradual increase in activity unless it's contraindicated. If they have unstable angina or non-STEMI, we're going to give aspirin and heparin. Dual antiplatelet therapy such as aspirin and clopidogrel or Plavix and heparin are recommended for non-STEMI patients. Cardiac cath with possible PCI is considered for both UA and non-STEMI patients once the patient is stabilized and angina is controlled, or if angina returns or increases in severity. And we need to determine, is this a STEMI or a non-STEMI? Serial EKGs reflect evolution of an MI, so that's the main reason why we are doing the serial EKGs. For non-STEMI, reperfusion therapy is initiated. Reperfusion therapy can include emergency PCI or thrombolytic therapy for STEMI. Again, the goal is to save as much heart muscle as possible. The advantages of PCI compared to thrombolytic therapy include it provides an alternative to surgical intervention. It's performed with local anesthesia. The patient is ambulatory shortly after the procedure, and the length of the hospital stay is approximately 3 to 4 days after an MI compared to the 4 to 6 days with the CABG or coronary artery bypass graft surgery, thus reducing hospital costs, and the patient can return to work several weeks sooner with the PCI compared to the 6 to 8 week convalescence after a CABG. So thrombolytic therapy is only indicated for patients with a STEMI. It offers the advantages of availability and rapid administration in agencies that do not have an interventional cardiac catheterization lab or one that's too far away to transfer the patient safely. Treatment of STEMI with thrombolytic therapy aims to limit the infarction size by dissolving the thrombus in the coronary arteries and reperfusing the heart muscle. The goal is to give the thrombolytic within 30 minutes of the patient's arrival to the ED, and all thrombolytics are given IV. Because all thrombolytics lyse the pathological clot, they may also lyse other clots, such as if it's a postoperative site. Therefore, patient selection is important because minor or major bleeding can be a complication of therapy. Inclusion therapy for thrombolytic therapy are chest pain less than 12 hours with 12 lead EKG findings consistent with acute STEMI and no absolute contraindications. Patients with chest pain lasting 12 to 24 hours with ECG changes supporting STEMI can be considered for thrombolytic therapy. Coronary revascularization with CABG surgery is recommended for patients who fail medical management, have left main coronary artery or 3-vessel disease, are not candidates for PCI, have failed PCI and continue to have chest pain. CABG can also be the option for patients with diabetes, left ventricular dysfunction, or chronic kidney disease. CABG surgery and PCI are considered palliative treatment for CAD and not a cure. So the internal memory artery is the most common artery used for bypass graft. It is left attached to its origin, the subclavian artery, but then dissected from the chest wall. Next, it's anastomosed or connected with sutures to the coronary artery distal to the blockage. Saphenous veins are also used for bypass grafts. The surgeon endoscopically removes the saphenous vein from one or both legs. A section is sutured into the ascending aorta near the native coronary artery opening, and then sutured to the coronary artery distal to the blockage. The use of antiplatelet and statin therapy after surgery improves vein graft patency. Radial artery is another potential graft. It's a thick muscular artery that is prone to spasm. Perioperative calcium channel blockers and long-acting nitrates can control the spasms. Patency rates are not as good with the IMA, but better than the saphenous veins. For acute coronary syndrome, the drug therapies that we can use are IV nitroglycerin or Tridil, and that's used in the initial treatment of the patient with acute coronary syndrome. The goal, again, is to reduce anginal pain and improve coronary blood flow. Morphine is the drug of choice for chest pain that is unrelieved by nitro. As a vasodilator, it decreases cardiac workload by lowering myocardial oxygen consumption, reduces contractility, and decreases blood pressure and heart rate. In addition, it can help reduce anxiety and fear. Beta blockers decrease myocardial oxygen demand by reducing heart rate, blood pressure, and contractility. The use of these drugs in patients who are not at risk for complications of MI, such as in cardiogenic shock, bradycardia, hypertension, it reduces the risk of reinfarction and occurrence of heart failure. And then the beta blockers will be continued after discharge from the hospital. Angiotensin converting enzyme inhibitors and angiotensin receptor blocker inhibitors should be started within the first 24 hours if the blood pressure is stable and there are no contraindications, and they will be continued indefinitely as well. Dysrhythmias are the most common complications after an MI. In general, they're self-timing and are not treated aggressively unless they are life-threatening. A lipid panel is obtained on all patients with acute coronary syndrome. All patients with ACS or diagnosed with CAD should receive lipid-lowering drugs indefinitely. After an MI, the patient may be predisposed to constipation because of the bed rest and opioid administration. So stool softeners like Colace are given to facilitate bowel movements, and this prevents straining and the resultant vagal stimulation from the Valsalva maneuver. Vagal stimulation produces bradycardia and can provoke dysrhythmias. A patient is admitted to the coronary care unit following a cardiac arrest and successful cardiopulmonary resuscitation. When reviewing the healthcare provider's admissions orders, which order should the nurse question? Oxygen at 4 liters, morphine sulfate 2 milligrams IV every 10 minutes until the pain is relieved, TPA 100 milligrams IV infused over 3 hours, IV nitroglycerin at 5 mics per minute and increase every 3 to 5 minutes. The answer is C. Traumatic or prolonged more than 10 minutes cardiopulmonary resuscitation is a relative contraindication for the administration of fibrolytic therapy. Chronic stable angina and acute coronary syndrome nursing assessment includes subjective data such as family history, indigestion, heartburn, nausea and vomiting, urinary urgency or frequency, straining of the stool, palpitations, dyspnea, dizziness, weakness, chest pain, stress, depression, anger, and anxiety. And for all of those, we do have management, such as health perception, health management, family history of heart disease, sedentary lifestyle, tobacco use, etc. We can also provide nutritional and metabolic counseling, elimination, try to avoid straining when you're trying to have a stool, activity and exercise. Do they have problems with palpitation, dyspnea, dizziness, and weakness? What is their cognitive perception? Is there substernal chest pain or pressure described as squeezing, constricting, aching, sharp, tingling, possible radiation? And how are they coping? What is their lifestyle? How do they handle their stress? Are they depressed? Do they have anger and anxiety? Do they have a feeling of impending doom? So our nursing assessment, the objective data includes anxious, fearful, restless, or distressed feelings. Are they cool, clammy, or pale, or ashen? Do they have tachycardia or bradycardia? Do they have pulsus alternans or pulse deficit? Do they have dysrhythmias? Have they developed abnormal heart sounds such as S3 and S4? Do they have hyper or hypotension? And have they developed a murmur due to damage to the papillary muscle? So our overall goals are to relieve their pain, preserve their heart muscle, give immediate and appropriate treatment, effective coping with illness-associated anxiety, participate in rehab, such as cardiac rehab, and reduction of risk factors. Our acute interventions, again, are to position the patient upright unless contraindicated, assess their vitals, get a 12 lead, provide prompt pain relief with nitroglycerin followed by opioids, assess their heart rate and breath sounds. If their blood pressure or heart rate are elevated, we need to auscultate the heart, which may reveal an atrial S4 or ventricular S3 gallop. A new murmur may occur during an anginal attack that can indicate ischemia of the papillary muscle of the mitral valve. The murmur is likely to be transient and disappear when symptoms stop. We also need to ask the patient to describe the pain and to rate it on a scale of 0 to 10 before and after treatment to evaluate the effectiveness of the interventions. So for their acute pain, we're going to give nitro, morphine, and oxygen, continuous monitoring with an EKG, look at the ST segment to see if it is elevating or going below the isoelectric line, listen to breath sounds and heart tones, vitals, pulse ox, INO, and again, provide rest and comfort. We want to balance the rest with activity, and when everything is all done, the patient would go into either a phase 1, 2, or 3 of cardiac rehab. Phase 1 occurs in the hospital. It's important that the patient understands the reasons why their activity is limited but not completely restricted, and we'll gradually increase them as they are able to tolerate. Phase 2 begins when the patient is discharged home and continues for 2 to 12 weeks, and that's when the patients are monitored with the telemetry unit. And phase 3 is long-term maintenance for optimal cardiac health, which can be done either in the home or they can go to a cardiac rehab facility as well. For patients having coronary artery bypass graft, care is provided in the ICU for the first 24 hours to 36 hours. Ongoing and intensive monitoring of the patient's hemodynamic status is critical. The patient will have numerous IV lines for monitoring cardiac status and other vital organs. These include a pulmonary artery catheter for hemodynamics, an intra-arterial line for continuous BP monitoring, pleural and mediastinal chest tubes for chest drainage, continuous EKG monitoring, an ET tube connected to mechanical ventilation, epicardial pacing wires for emergency pacing of the heart, a urinary catheter to monitor urine output, and an NG tube for gastric decompression. Most patients will be extubated within the first 6 hours and transferred to a step-down unit within 24 hours for continued monitoring of the cardiac status. Complications are primarily postoperative, develop after CABG surgery relating to the use of cardiopulmonary bypass, or CPB. Major consequences of CPB are systemic inflammation, which includes complications of bleeding and anemia from damage to the red blood cells and platelets, fluid and electrolyte imbalances, hypothermia as blood is cooled and it passes through the CPB, and infections. We want to focus your nursing care on assessing the patient for bleeding, especially from the chest tube drainage and the incision sites, hemodynamic monitoring, checking their fluid status, replacing their electrolytes as needed, and restoring temperature with warming blankets. Postoperatively, they can have dysrhythmias, specifically atrial tachydysrhythmias, and are common in the first 3 days after CABG surgery. Beta blockers should be started as soon as possible after surgery unless it's contraindicated to reduce the incidence of AFib. Again, in ambulatory care, they can have cardiac rehab, patient and caregiver teaching, and their physical activity is measured by the metabolic equivalent scale. So basically, they are going to report to their nurses in cardiac rehab not what their heart rate is, not what their blood pressure is, but how hard do they feel that they're exercising. And it's on a scale of either 1 to 5 or 1 to 10. But their heart rate will be monitored. And again, their exercise is going to be based on their activity abilities and increased accordingly. So it'll start out low-level stress, and we also need to determine whether they need isometric versus isotonic activities. Isotonic activities include changes in muscle length and joint movement with rhythmic contractions at relatively low muscular tension, such as walking, jogging, swimming, biking, and jumping rope are examples of activities that are isotonic. It can be done in a safe, steady load on the heart and lungs and improve the circulation in many organs. Isometric involves the development of tension during muscular contraction, but produce little to no change in muscle length or joint movement. So lifting, carrying, pushing heavy objects are isometric activities. Because the heart rate and blood pressure change rapidly during isometric work, isometric exercise should be limited. When discussing activities restrictions and expectations after discharge with MP, he assumes his sex life is now over, as he does not want to die having sex with his wife. How would you respond to that? Resumption of sexual activity, we can teach them to discuss other physical activity. They can get erectile dysfunction drugs, but they have to have a healthy heart. And if they're taking nitrates of any form, they cannot take erectile dysfunction drugs. Prophylactically, nitrates can be taken before sexual activity as long as they are not taking ED drugs as well. They should avoid sex when they're having any type of chest pain. The patient needs to delay sex after a heavy meal or excessive intake of alcohol when extremely tired or stressed or with unfamiliar partners. They should also avoid anal intercourse because of the likelihood of eliciting a vasovagal response. The patient can resume sex based on his or her partner's emotional readiness and the assessment of the extent of the recovery. It's generally safe to resume activity 7 to 10 days after an uncomplicated MI. However, some believe that the patient should decide when he or she is ready to resume sex. Others believe patients must be able to climb 2 flights of stairs briskly without dyspnea or chest pain before sexual activity is resumed. We also need to provide the patient with reading material on resumption of sexual activity to facilitate discussion. Calmly and matter-of-factly introducing the subject of resuming sexual activity during teaching about physical activity has positive effects for your patients. The overall expected outcomes are that the patient with acute coronary syndrome can maintain stable signs of effective cardiac output, report relief of pain, report decreased anxiety and increased sense of self-control, achieves a realistic program of activity that balances physical activity with energy-conserving activities, and describes the disease process, measures to reduce risk factors, and rehabilitation activities necessary to manage the therapeutic regimen. Sudden cardiac death is unexpected death resulting from a variety of cardiac causes. Almost 400,000 people experience SCD yearly. In sudden cardiac death, there is a sudden disruption in cardiac function, producing an abrupt loss of cardiac output and cerebral blood flow. The affected person may or may not have a known history of heart disease, and SCD is often the first sign of illness for 25% of those who die of heart disease. Acute ventricular dysrhythmias such as VTAC and VFib cause the majority of cases of SCD. Structural heart disease accounts for 10% of the cases of SCD. Patients in this group include those with left ventricular hypertrophy, myocarditis, and hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is a risk factor for SCD, especially in young athletic people. Some cases of SCD, especially in people less than 45 years, occur in the absence of structural heart damage. These involve disturbances in the conduction system, such as a prolonged QT syndrome or Wolff-Parkinson-White syndrome, which are both congenital. People who survive an episode of SCD require a diagnostic workup to determine whether they have had an MI. Serial analysis of cardiac biomarkers and EKGs are done, and the patient is treated accordingly. In addition, because most persons with SCD have CAD, cardiac catheterization is done to determine the possible location and extent of the coronary artery occlusion. PCI or CABG surgery may be indicated. The most significant factor in long-term survival of a patient with sudden cardiac death is absence of underlying heart disease, rapid institution of emergency services and procedures, performance of perfect technique and resuscitation procedures, or maintenance of 50% of normal cardiac output during resuscitation efforts. And the answer is B, rapid cardiopulmonary resuscitation and prompt defibrillation with an automated external defibrillator and early advanced cardiac life support can produce high long-term survival rates for a witnessed arrest. The nurse is caring for a patient who survived a sudden cardiac death. What should the nurse include in the discharge instructions? Because you responded well to CPR, you will not need an implanted defibrillator. The most common way to prevent another arrest is to take your prescribed drugs. Your family members should learn how to perform CPR and practice these skills regularly. Since there is no evidence of a heart attack, you do not need to worry about another episode. And the answer is C. Rapid cardiopulmonary resuscitation, prompt defibrillation with an automated external defibrillator, and early advanced cardiac life support can produce high long-term survival rates for a witnessed arrest. Oops. Oops, wrong question, sorry. Yes, the answer is C. Questions? Thank you for your time.